So we'll be ready to start in just a few seconds. We'll just let all the participants link in. So welcome everyone to the Lessons in Bronchiectasis webinar series. And this is a webinar series organized by ERS and EMBARC, the Bronchiectasis Registry. And it's intended to let people, healthcare professionals, know more and learn more about bronchiectasis research and care. And we have two wonderful experts today, Letizia Traversi and Eva Polverino, and they're both from Barcelona, from Vall d'Hebron Hospital in Barcelona. And the topic of their talk today and the discussion today is bronchiectasis plus, which means bronchiectasis and other airways disorders and the association. So before I hand over, just a few housekeeping notes. You are encouraged to ask questions and make comments at the Q&A in the chat box, and we'll be monitoring those throughout the webinar. For those of you who wish to see translations, there's captions in various languages, which is a part of the Zoom feature. And it is on the show captions, and then click on the arrow to the right and leave the speaking language as English and select your language as the target language. There's more languages if needed. So there will be polls, and we encourage you to vote in the polls, and also a discussion and ample time for discussion. So we really look forward to your discussions. So with that, I will hand over to Professor Eva Polverino from Vall d'Hebron in Barcelona. Eva is an expert on bronchiectasis and a co-founder of EMBARC Bronchiectasis Research Network, and the one of the authors on the bronchiectasis guidelines from 2017. And it's a privilege to hear both Letizia and Eva today. So Eva, please.
Thank you, Michael, and thanks to both ERS and EMBARC to organize this kind of events. So I think the reason to choose this topic is quite simple. The topic is becoming more and more relevant to the scientific community, particularly to those of you who see and visit patients with bronchiectasis. Now, bronchiectasis is not a rare disease, and even the association of bronchiectasis with other airways disease is clearly not rare. We've seen that in the recent literature an increasing number of papers showing that it's quite common to see bronchiectasis in association with something else. Something else that could be COPD, that could be asthma, sometimes is not very clear. So this is one of the reasons I asked Letizia, that is a PhD student, to work on this topic to develop her doctoral thesis. And I think she's the perfect speaker to challenge you, to show you what we have in the literature, to discuss the doubts we have. This is the reason for any research question. So I think it's the right moment to talk about this. Maybe we won't have all the answers, but the point is to put the right questions when it is needed. And I think today it is the moment to ask these questions, because as you will see, having more than one respiratory problem in the same patient puts serious clinical challenges. What do we do to diagnose it? What do we do we treat it? And it's not very simple. So we'll hand over to Letizia. You will see that during her presentation, we will have some questions. You will be asked to vote. The questions will be an excuse to debate some topics. Don't expect to have the right answer all the time. Maybe it's not possible in some of the questions, but again, it will be a way to discuss this. Okay, we will have some questions during her presentation, and then we will have time to put your questions through the Q&A that we will use at the end of the presentation to have further discussion. So I'll hand over to Leti.
Thank you, Eva, and good afternoon, everybody. I hope I'll be clear enough to guiding you into this subject that it's, I think, that many of you will face in their daily life and daily clinical practice. So to start eating up a bit the audience, I'll start with a clinical case, a very basic clinical case that maybe you all had in your practice. It's a 77 years old male with not very important comorbidities, arterial hypertension and bladder cancer that was operated, an ex-smoker of 20 pack years accumulated smoke. He started with symptoms of dyspnea, of mucopurulent expectoration of 20 milliliters per day, 1 to 2 non-severe exacerbations per year, and he started with these symptoms at a quite old age, at 75, after an acute episode of bronchitis. He was studied for his bronchiectasis because these patients, of course, comes to our bronchiectasis clinic, and he has just a slightly elevated IgE, but no other alterations in the study. He has a severe obstructive pattern and a chronic infection from Haemophilus influenzae. This is his CT scan, some cuts, and we can see that there's some emphysema, there's some air trapping, and some bilateral bronchiectasis in the basis. So I'll just first question, what would you diagnose in this patient? Bronchiectasis with COPD, COPD with bronchiectasis, bronchiectasis with bronchial obstruction, or a bronchiectasis COPD? Let's start voting.
This patient was an ex-smoker, right, Letizia?
Yes, but with a high pack year, 20 pack years of accumulated smoke.
We will leave a few seconds to let people choose the answer they like most. You don't necessarily have to, don't worry about the answer, right?
Actually, almost none of these polls have a right answer. So it's just to discuss it a bit. Okay,
let's see who can see the answers. Okay, COPD with bronchiectasis, the most common answer with 57%, followed by bronchiectasis with COPD, almost 30%. What do you think, Leti?
Actually, I think I would agree with most of the people, because I think that the first trigger to these patients' symptoms and disease is COPD, but of course, he also has bronchiectasis. It is not wrong to say that he has bronchiectasis with COPD, because actually we don't know when he developed the bronchial dilatation. So we cannot be completely sure about what's the driver in the disease. I wouldn't say bronchiectasis with bronchial obstruction because it's a smoker. So we already have a reason for the bronchial obstruction. So I would leave this definition to some patient that has no reason to have an obstruction, but it's bronchiectasis. And
what about bronchiectasis COPD?
It's something that I've seen
people
a lot.
Voted.
Yeah, it's something that I've seen a lot, but actually we don't really use it. This is not a category that it's used nowadays. So I think it's the most, the less relevant between all these answers. So Eva, what would you comment?
Well, I agree with you. It's at the moment we don't have reasons to say we can use this kind of definition, but I do remember that I received this kind of referral for a patient that came to my attention because of COPD because of bronchiectasis, like secondary to bronchiectasis, and possibly it is because of the last guideline saying that you can have COPD because of a number of reasons, many reasons. It could be a lot of long list of things that, in theory, if you consider COPD just as a spirometric definition, then it could be. But in our case, I mean, the way we work and think in bronchiectasis is not exactly like that. But as you see, it's not easy. And there is no single question that can be considered the right one.
And let's see what at the end of this presentation you'll have some more clear idea or not.
Excellent.
So let's start, if my presentation works. Okay. By having just a quick look to bronchiectasis, we know that bronchiectasis is a heterogeneous disease with a lot of different symptoms: cough, sputum production, dyspnea, hemoptysis, fatigue, frequent exacerbations. But we know that also other chronic respiratory diseases share some of these features, especially asthma and COPD. So sometimes in the same patient, we can have all these symptoms and symptoms that are not so clearly relatable to bronchiectasis. So how do we face this patient? What's our diagnosis, and how can we do the best for our patients? Looking into airways comorbidities. Why is it important? Well, first of all, I wanted to start with an example. We can see these 4 old guys that could be our patients that look like just 4 normal people, even if someone can have recognized that they are the Rolling Stones and they still rock on the stage at their quite advanced age. This is to say that sometimes the whole is more than the sum of its part. So 2 different diseases in the same patients do not work as 2 different entities, but they have synergic processes that can be important to consider. So why is it important in clinical terms? First of all, because it helps us to identify phenotypes. We will see that there are clinical differences that have been described in patients with comorbidities that make this subgroup different from pure bronchiectasis patients, and differences especially in outcomes. It's important to personalize the treatment, not only because in case of more than one disease, we can have different tolerance and different contraindications, but it's important because in some regions, in some countries, cost reimbursement is different. So we need to also find the right definition to find and proportion, especially the right treatment. And also it's important to give patients a sense of belonging, to give them a complete answer to their question, why am I feeling bad, can help them feel part of a recognizable group, comprehend better the disease, and also be included in trials or have access to services that could not be available if we don't have the right diagnosis. So let's start with the first comorbidity, bronchiectasis and asthma. First of all, when would you diagnose bronchiectasis and asthma? Again, there are no right answers, but if the patient has a positive bronchodilator test, a positive challenge test, for example, methacholine, in case of peripheral eosinophilia, in case of sputum eosinophilia, if there are clinical symptoms, wheezing and dyspnea, or in none of these cases. We can choose more than one.
It's good you put the option of choosing more than one answer, because I think this is the most difficult question you'll probably be showing today. We have been debating this issue for months, and we still do not have the answer. So feel free to answer what you feel.
Actually, we'll speak about every single step during the presentation. So it means that everything could be, but we're interested in seeing what would you choose.
Yeah, it's a way to share opinions somehow, to see what people feel about diagnosing asthma in bronchiectasis patients.
And feel free to use the chat if you want to discuss or develop more your answer, or if you're not agreeing with ours.
Mm. Let's see if we have the answers. Here we go. Very good. So,
Okay.
Lady, you have a good distribution.
Yeah.
So we have a lot of people are answering the positive bronchodilator test is very important to diagnose asthma. Yeah, right, like 86%. And then we have, with the same percentages, a positive challenge test that in theory should correspond to a bronchodilator test in pathophysiological terms. The same percentage would be for wheezing in dyspnea as clinical history. And then and also you have peripheral eosinophilia, right? Less frequent sputum eosinophilia. So up to you to comment this.
Well, actually, as I said, there is not a real answer to this question because we don't have it clear. Even in the bronchiectasis community, there is not a definition. Now we will see that. Also because we have to remember that our patient already has an airway disease. So some of these alterations could be due directly to bronchiectasis, could be isolated. We can have a patient with wheezing, but with no positive bronchodilator test nor positive challenge test. Or we can have bronchodilator test that changes according to the stability or the exacerbation. So I think that the most challenging thing in bronchiectasis patient is that we cannot consider them completely as healthy patients, or not healthy, but with virgin patients that we haven't studied yet. So we will see now during the presentation. But I think that it was nice to see also the sputum eosinophilia that was less represented, and I think that it's because it's not something we would actually do on in clinical practice, at least not usually.
Yes, Letty, Eva, can I just add on something? I really find it useful to question patients about the age where symptoms started, because asthma is typically starts at a very young age, so that could be also helpful.
Yeah, of course, and also understand when these symptoms are present. But let's go on and we will discuss a bit more with the data we have. So, okay. First of all, one of the things that make everything more complex is that asthma is a complex disease and has a complex definition, even just in the GINA guidelines. Diagnosing asthma requires clinical symptoms, require a typical history. So it's very important to question the patient about his symptoms, the onset, the frequency of symptoms, and also requires variable expiratory airflow limitation that can be assessed in many different ways. What are the problems in bronchiectasis? That some of these are common features. I don't know if someone in the audience can relate to this personal experience, but we have patients that just wheeze because of the quantity of sputum they have. So they have like a variable obstruction that resolves after expectorating, or we have patients with hyperreactivity during acute phases. Tests are not always available because these are not usual parts of the bronchiectasis follow-up, and we'll come back on this topic later. we don't have data about the meaning of some of these tests in bronchiectasis patients. There are just few studies about FeNO. There are very few studies about methacholine, and reversibility can be non common finding. I mean, we are doing a study in our hospital, and we see patients with just transient bronchodilator responses. So it's quite complicated in patients that are already experiencing an airway chronic inflammation. Also, we have to remember that eosinophilic bronchiectasis exists, and they are not the same as asthma and bronchiectasis. So how do we define asthma? Well, right now, to interpret the results of the EMBARK data, we had to rely on the clinician diagnosis, on the reported diagnosis of the patient. You can use these QRs to access easily to the papers if you like. So in the almost 17,000 patients in the registry, 31% were reported as having asthma, more than 5,000. These patients had common characteristics. They were younger, more likely to be female, never smokers, compared with, of course, pure bronchiectasis patients, with higher BMI, with higher rates of chronic rhinosinusitis, peripheric eosinophilia, and Aspergillus IG, raised Aspergillus IG, so sensitization. And in these patients, ICS was associated with a reduction in mortality and hospitalization. We'll come back to the ICS theme when we'll talk about treatment. So don't worry, I'll just leave it hanging for a bit. About outcomes, we saw that these patients had lesser severity. They were less severe than pure bronchiectasis patients, but with lower quality of life. They had more frequent exacerbations, but less severe exacerbation and less need to be hospitalized. Also, peripheral eosinophilia was more common, and also as we said, specific IgE to Aspergillus, and even there was almost an 8% of patients with diagnostic criteria for ABPA at baseline, at their first visit. It is possible that these data are biased, because we can see just a small percentage of bronchiectasis patients without asthma were tested for eosinophilia and for Aspergillus sensitization. So it is possible that those patients already had symptoms that led the clinicians to test them. We don't know it for sure, but it means that maybe the difference between these two sets of patients is even wider. Let's pass to bronchiectasis and COPD. In older series, the prevalence of bronchiectasis in COPD patients or COPD in bronchiectasis patients was very variable. And this depended on different things, especially inclusion criteria in the studies. The definition of the disease was different, the severity considered, and the radiological methods used to define the bronchiectasis, but also because of a diagnostic error derived by differences in the bronchoarterial ratio, depending on factors that are not related to the bronchi. For example, in the pulmonary hypertension, we can have a lower ratio because of a vasodilation, an increased diameter in the arteria, or on the opposite side, hypoxic vasoconstriction raises the bronchoarterial ratio, but not because of dilatation of the bronchi. Also, the inclusion of non-significant bronchiectasis can change this prevalence. So we can see how in previous series, there's a diagnostic bias. And that's why we were we thought that we needed to define better this kind of association. It is true that a rose would smell the same with another name, but it's the same with the diagnosis. And that's why we made, within our group of the EMBARC, the rose consensus definition through a Delphi survey involving more than 100 physicians throughout Europe. We tried to define this in the most objective, as objectively as possible, this association. And this is the definition we selected. That was the most voted, let's say. So to define the presence of bronchiectasis and COPD, we need radiological signs of bronchiectasis. We need an obstructive pattern, symptoms that can allow a diagnosis of clinical bronchiectasis, and exposure to toxics, especially smoke or other toxic exposures. We will see why this was important, or we think it's important, by looking into the EMBARC data. We recently published this paper about COPD in the registry. We had 25% of patients with a reported diagnosis of COPD as cause or comorbidity. These patients, again, were quite characterized. They were older, more likely to be male, with higher BMI, with more inhaled medications, long-term oxygen, non-invasive ventilation, and macrolides. They were using less airway clearance and inhaled antibiotics, and they had a slightly increased levels of Pseudomonas aeruginosa, even if this was not significant. As for the outcomes, severity was higher and quality of life was lower. They had more exacerbations and more hospitalizations compared with bronchiectasis patients without COPD. Let's see what happens if we apply the ROSE definition to this, to EMBARC dataset. We can see how the prevalence lowers to a 20%. It was 25 reported and 20% the objective prevalence using this definition. And we can see that almost a quarter of patients reported as having COPD actually had no obstructive pattern, and almost a third of them had no history of exposure. Of course, these could be linked also to differences in the compilation of the registry. The registry is as good as the data we put in, but could also be secondary to other causes. And when we look at outcomes using the ROSE definition, we can see that patients fulfilling the definition and with a reported diagnosis had greater severity, more mortality, more exacerbations, and more hospitalizations. And the second group is the one without the criteria, but with a COPD reported by their clinician, meaning that maybe the severity of the disease was used as a criteria to define the presence of a second disease. We can see that there is a decreasing trend in severity between these four groups, so COPD reported and the presence or not of the ROSE criteria. And it is clear that the group fulfilling the criteria has a greater severity than the rest of the groups. It is possible, it has been described by this nice work, that there's even a distinct endotype in this set of patients. In this study, both the proteomic analysis and the microbiomic analysis demonstrated that COPD and bronchiectasis tend to be more similar as an endotype, more similar to those of bronchiectasis, pure bronchiectasis patients than COPD patients. The COPD are those in light green, and the other two groups are actually almost overlapping. So maybe it is actually a different pathogenesis and not only a different phenotypical expression. To trying to compare these two groups, we can see that asthma patients and COPD patients are actually two quite different groups in terms of age, of sex, of severity and mortality, of exacerbation risk, use of medications, and microbiology. So it is true that we are facing two different entities, or at least this is what data suggests. And this is a bit to fix it, to have a, we can actually identify two different characters in these groups of patients. Let's not forget the upper airways.
Letty?
Yes.
Maybe this would be a good time, because I see there's two really interesting questions that really are worth a discussion.
Of course.
So the first is in patients with bronchiectasis and pulmonary hypertension, and a question about the signet ring sign, which may be false negative. So Eva, Letty, do you want to try and answer that question?
Maybe Eva?
Eva, I think you're muted.
Sorry, because I was typing. I didn't want to make noise. Sorry. So in pulmonary hypertension, it is supposed you have like a vessel dilatation. So you would clearly see, like, you could not see adequately the ratio. That is true, but in general, I mean, it's difficult. So it's always a problem of having the balance. That's the reason we had a lot of discussion with the radiologists. In our survey, we included chest radiologists because of this. It's not easy. So all the definitions, radiologic. Also, the other question is about the presence of bronchiectasis in more than one lobe. There was a lot of discussion, so it wasn't general agreement in this sense. But if you think about the ring sign, it's difficult. You can have false negative, false positive. There is a nice paper where we showed exactly, I mean, if you look at the ratio, of course, you can have misdiagnosis, right? And for this reason, we use more than one criteria, not only radiology, but also compatible symptoms, exposure, and what am I missing, Letty? So Rose radiology, obstructive pattern, obstruction, exposure, and symptoms. So yeah, and symptoms. Yeah, this is the good thing of having a composite definition, right?
Yes, and also Michal.
Sorry, and the more severe the radiology is, the less likely you are to make a mistake. So if you have really varicose or cystic bronchiectasis, then you're pretty sure that it's both COPD and bronchiectasis.
Yeah. And also, no, I think that this definition was made also in order to have an objective definition for clinical trials, for research. Of course, the clinical practice can be different. And if you have a patient that is very symptomatic for bronchiectasis, even if you could be in doubt about the bronchoarterial ratio, you always have to link it to the clinic. So if the patient has no signs of bronchiectasis, it is probably not a bronchiectasis patient. So,
and usually if you have pulmonary hypertension, you also have other signs that suggest, radiological signs that suggest it. So the ring sign could be a very minor issue in this context, because if you have pulmonary hypertension, you see, you know, a cardiac dilatation, you have other clear radiological signs, and only, you know, small bronchiectasis could, small rings could become false negative. So it's a relatively minor issue in this sense.
Okay, great. Thank you.
Okay. And thanks for participating. I was saying that sometimes we forget about upper airways, but they are very important, as we will see. It is clear that another question for you. This is just to see what's your perception of the prevalence of CRS in your patients, or if you have the data, of course, but how frequent do you think it is in your patients?
Yeah, I think perception in this field is particularly important, and is mostly related to the kind of experience you have. For example, you have a colleague hear throat and nose working close to you. If you depends on your experience with this, but you will see it's not easy. It's more about perception and experience than about real assessment of this in practice. But we are working on this topic as well. So please choose less than 25%, 25 to 50% as second option, 50 to 75% or more than 75%. So the big majority of our patients. What do we want? One option, right, Letty? Okay.
Yes.
So you see, there is a quite homogeneous distribution of answers. That
Yes.
I think is what we expected, right?
Yes, because we will see that even literature has very different distributions. And in this case, the diagnostic bias is not that relevant. So it is probable that there are some things or that we do not consider when we are looking into our patients' symptoms and general clinic, or there are some variabilities, geographical or genetical, that we are not aware of. I don't know if Michal wants to say something, because this is one of her main interest fields. So
yes, thank you. Actually, it's very interesting, and we looked at EMBARC data and found about 20%. And of course, different etiologies of bronchiectasis have different prevalences of rhinosinusitis. And of course, if you have PCD, you're more likely to have rhinosinusitis, but other etiologies have rhinosinusitis as well.
There was an older study we performed, like not myself, but I was in the hospital where I was working. It was like 20 years ago. It was published, and about 70% of patients with bronchiectasis were all screened for sinusitis, and they had some kind of sinusopathy. So it depends on how you look for them and the experience, and if you have a colleague right close to you. So again, but the registry is like just based on what clinicians think
Yes.
of their patients. That's the point. So there is a huge difference. It could be because of the way you look for it, you investigate it, and the tools you have, the availability to test this. Lady,
yes,
in your hands again.
it is true that it's not that strange that we have a lot of CRS in patients with bronchiectasis, because we know that the epithelium is the same from the nose to the bronchi. So there's a continuum, and also the inflammation in this epithelium can be shared between the upper and the lower airways. As you can see in literature, the prevalences are very different. We have this review, this meta-analysis, with a 72% of patients with CRS. The EMBARC registry, as Michal was saying, 21%. The USA registry gets 45%, while in the Korean registry, just a 7%. And they did all the workouts, because I've been looking if there was some difference, and they actually were diagnosing more or less like in the other studies. So for sure, there's something that we should look into to understand the reasons for this difference, and maybe, again, the way we look at the patient, as Eva and Michal were saying. About this kind of patients, almost all these studies agreed that CRS was more associated with idiopathic bronchiectasis. Patients had more symptoms, not just upper airway symptoms, but also more bronchiectasis symptoms, more lower airways. They had worse quality of life. They had a similar or even higher severity of bronchiectasis, so even if symptoms were more evident, the radiology was not that different in many cases. They had more frequent exacerbations, but mild exacerbations. They had higher prevalences of eosinophilic inflammation without having asthma, and they had their lower airway symptoms were improved when the upper problem was fixed, especially after sinus-nasal surgery. So these two look like a third different group of patients. In this study that was recently published by Michal, not only they had similar, they had more eosinophilia, but with a phenotypical and even endotypical pattern different than asthmatic patients, but they also had differences in the interactions between the pathogens, between microbes more than pathogens, even if the microbiome wasn't that different between the two groups, the CRS and no CRS. So it means that there's something else that triggers differences in this kind of interactions. So how would we diagnose airways comorbidities in bronchiectasis? Of course, we need to ask ourselves if a comorbidity can be present when we see that there are symptoms that do not allow us to completely define the disease. We can have persistent cough, even if all the rest of bronchiectasis symptoms are controlled. We can have a clinical history suggestive, for example, of asthma, familiar history, or symptoms that vary according to the to allergen presence or dust, for example. We can have patients with wheezing, with upper airway symptoms, or with exacerbation that are not infective, so that do not completely fulfill the bronchiectasis exacerbation criteria. Every time we have a doubt, we should dig deeper. We should try to find the next diagnosis. One of the main items we have in our toolbox are lung function tests. We know that in bronchiectasis, lung function has not just a simple functional presentation. We have heterogeneous lung function. We have patients with normal lung function, with obstruction, with restriction, and we know that the prognostic value of the spirometry in pure bronchiectasis patient is not that high. We can use other tests. We can see in this paper the comparison of FeNO between different diseases, and we can see that bronchiectasis has levels of FeNO that are not dissimilar to COPD or pneumonia or other patients. Yet we have very little data about FeNO, about methacholine. So this is something that we should tailor to each patient. In your bronchiectasis clinic or in your bronchiectasis patients, what do you usually do? This is just to see a little bit how you manage your patient and how frequent it is in different contexts to perform different tests. Again, no answer is correct.
Thanks, lady. So I think this is the question we put when we decided what you could do for your thesis, right, lady?
Yeah, we are doing a complete lung function assessment on bronchiectasis patients without known comorbidities. And actually, it's quite interesting because, for example, we see a lot of funny things happening with bronchodilator tests. We see funny things also
FeNO as well.
FeNO level. We have almost a quarter of patients with alterations with raised FeNO without other signs of, for example, eosinophilic inflammation. So we are still running with this, but well, we hope we'll have some more answer to.
Let's see if we get some inspiration from the audience. So they say spirometry work with bronchodilator test, 85%, plethysmography and DLCO, 35%. Simple spirometry, that is what we usually do more or less everywhere. Only few people talk about FeNO or methacholine. Yeah, so bronchodilator wins at the moment.
Yeah, I think that, for example, in our center, we don't do it that often. We almost always do spirometry, and from time to time, every year or couple of years, plethysmography and the LCO. Maybe this is because of the cystic fibrosis heritage, where usually patients are followed up for a long time just with simple spirometries. So it's...
Well, I have to say that this year, as after analyzing what we have and what we don't have in the literature, I started to ask for spirometry plus bronchodilator test in most of our patients. And like volumes in DLCO, I think it's particularly important in those patients with an associated autoimmune or autoinflammatory diseases, because they could have just DLCO, reduced DLCO as the only disorder, functional disorders that you can find because of the systemic inflammation. Let's see. Let's go on.
Okay. Wait. Okay. So just to have a recap, of course, we can use all the tests we had in the question. Plethysmography and the LCO can help, for example, assess the presence of hyperinflation, so help in a diagnosis of COPD, while bronchodilator tests can help diagnosing an asthma, of course, even if, again, we have there are data testifying that patients with bronchiectasis have hyperreactivity only during exacerbations. So we need to be sure about when we are testing our patient that is in a stable state, he or she. And also we can use other tests, FeNO, methacillin challenge, always considering the clinical context. So this can be a bit of a disappointment. There is not a rule, there is not an indication that fits for all, but the thing is, consider the clinical context and act putting all the pieces together. Another tool that we could use are questionnaires, especially for CRS. The sinonasal outcome test is a test quite easy, that doesn't require any other instrumental test, and could be very useful to identify patients with a CRS, or at least that deserve to extend the study. Laboratory testing can be useful because we can check, for example, simple lab blood CBC, and we can see that there are eosinophils. So we have to ask ourselves, is there asthma? This patient could have an ABPA or another Th2-related comorbidity. Raised levels of IgE, of course, always remember that ABPA exists and is not that infrequent in patients with bronchiectasis. And the isolation of potential pathogenic microorganisms, it's very important, because if we don't have a complete assessment, a frequent assessment of sputum in these patients, we should miss a chronic infection that could be the trigger to the increase in symptoms, or even in the appearance of different symptoms. So always test your sputum of your patients, of course, not yours. Okay, chest CT is fundamental in bronchiectasis, as we know, for the diagnosis, but can give some valuable information also about other diseases. Again, we have to check for the typical signs of other diseases, for example, bronchial thickness, air trapping, or emphysema, that can be indicative of a second disease, especially COPD or asthma in some cases. Remember that in patients with higher upper airway symptoms, or for example, headaches with symptoms compatible with sinusitis or polyposis, the CT, the sinus CT, could be fundamental to have a diagnosis and to grant our patients the right treatment. talking about treatment. When 1 + 1 doesn't equal 2. When we have two different conditions, we could try to treat both independently, but sometimes this could be tricky, especially in bronchiectasis. Guidelines, the bronchiectasis guidelines, recommend bronchodilators only in case of breathlessness, before physiotherapy or, for example, hypertonic saline solution nebulization, or in case it is required by the presence of asthma or COPD. So there is not a real, evidences are real low for bronchodilators in bronchiectasis, but if we have a comorbid airways disease, we have to treat it. So we need the bronchodilator. ICS, I think this is the most, the strongest question. Yes or no, ICS in bronchiectasis? Only in exceptional cases, only if we have asthma, if it's necessary to control breathlessness, if clinical symptoms require it, for example, wheezing or hyperreactivity, even if we don't have an asthma diagnosis, if there's eosinophilia, what would you do?
It's a tricky question, and we have to remind that over 60% of all bronchiectasis patients in the EMBAC registry are taken in ICS without a clear indication in many cases, possibly because it's an heritage from the past where we're giving ICS to everybody, any kind of chronic disease, or possibly because we simply don't know, so we give more, although there could be some risks associated with extra medication. Let's see the results. Okay, so asthma, in presence of asthma is the most common one, or wheezing.
Okay. I think this has a lot of sense as answers, especially considering the data we had so far and the also the recommendation of the ERS. I would already go to the ERS guidelines about corticosteroids because I think they explain a lot of the answers. ICS are contraindicated in the guidelines because of an increased infection risk and increased risk of NTM. Actually, these increased infections have been demonstrated in some works, in some others there was no difference, but anyway, the idea is not to assume this risk. Anyway, some things have changed. In the paper I presented you before, the asthma and bronchiectasis EMBARK paper, we saw that the use of ICS in asthmatic patients had a protective effect, lowered the mortality, hospitalizations, and exacerbations without implying a worsening in these outcomes in patients using ICS without asthma. This is a new data. This is something that we weren't expecting, I think, and that changes a bit our predisposition towards corticosteroids. Of course, we don't have so many data yet. We don't have clinical trials to support the use or not of ICS, but it looks like at least if we use them in the right patient, we are granting him a better outcome. And if we are using it wrong, at least we are not harming the patient. And I think this is a very important message, very important data coming from the EMBARK registry. Also, it was demonstrated that patients with peripheric eosinophilia, tend to exacerbate more, but not if they have an ICS. These were patients without asthma, meaning just plain bronchiectasis patients. Probably there were some patients with asthma, but we can see how, mocking a bit the COPD data, it looks like the use of ICS in eosinophilic patients is beneficial. And this has been actually confirmed in a paper about the use of ICS in the EMBARK registry that is on press. So you will see it in a few weeks, I guess, where we saw actually a benefit in patients with peripheric eosinophilia when using ICS. And it's quite clear, especially in exacerbations and hospitalizations. So maybe it's time to change a bit the paradigm.
Lady, we have 5 minutes to the end.
Yes, I think there will be just enough to just wrap up a bit the indications of bronchodilators and ICS. Bronchodilators are indicated when there's bronchiectasis and COPD, but just in case of symptoms or pre-treatment in patients with pure bronchiectasis or with asthma. ICS is, of course, indicated in bronchiectasis and asthma, and probably it could be beneficial in the other two groups if eosinophilia is present. While for other treatments, I haven't gotten very specific about this, but inhaled antibiotics, of course, are indicated in bronchiectasis. There's the considerable risk of bronchospasm in patients with asthma. It doesn't mean that they are completely contraindicated, but we have to take care of this risk. We have to keep it in mind, and it could probably prevent many patients from tolerating the antibiotics. In COPD, there are low evidences, but growing evidences. So it is possible that soon they will be also available for this kind of patients. Macrolides, fantastic for everybody, even for CRS, because they
reduce inflammation on all of them.
Yes, they lower exacerbations, sorry. Physiotherapy and mucoactive treatments have to be used with care carefully in patients with asthma because of the risk again of bronchospasm. Exacerbations. This is another interesting thing. Not all bronchiectasis exacerbations need antibiotic, especially in case of comorbidities. We can have non-infective but inflammatory exacerbations. So we always need to take a good look to the symptoms the patient refers and refer them to the HEALS criteria. So we always need to find at least 3 symptoms for at least 48 hours, requiring a treatment change. Bronchiectasis patients, even in case of a second disease, are already hyperproductors. So the presence of sputum is not enough. We need a change in sputum. We need a change in density or in the quantity. Dyspnea, fatigue, cough can be indicative of a COPD exacerbation or an asthmatic exacerbation. So not always treat with antibiotic, always treat according to the real clinic situation. In conclusion, I'll be very rapid. Different diseases make different patients. So we saw how we have phenotypes, quite distinct phenotypes, and elevated prevalence of airways comorbidities in bronchiectasis. Don't stop with the bronchiectasis diagnosis, but if you're in doubt, consider the comorbidities and consider using other tools that are not specific of bronchiectasis, always taking into consideration the big picture, the context, the entire context of the patient, and listen to the patient, because patients usually know what's their main problem, and it could not be the one we are looking for. Always remember that different patients, different diseases, different treatments, so tolerance can be impaired, outcomes can be different in patients with comorbidities. ICS, not always, of course, but in asthma, they are absolutely necessary. When eosinophilia, you can consider them. You can do a clinical proof, and if they work, you can leave them to your patient, checking their sputum culture, checking for this increased infectious risk. And remember that acute doesn't mean always infected. So use antibiotics when it's necessary not because they have bronchiectasis, they will always need an antibiotic. And in general, this is I think the most general indications of all, but it's true. One size doesn't fit all. So if there are airways comorbidities, personalize the treatment. And remember all the possibilities you have. So thank you to the EMBARC organization, to the EMBARC Working Group on Airways Diseases, to my beautiful team where I am very lucky to work in, and thanks to all the patients because we do it for them and because of them. So we'll go on this way. And I think that Eva wanted to say something.
Yeah. Just a final thought about Tobias Welte. I think he passed away just a week ago, and it is the first event we organized from EMBAC side after he passed away. I really want to thank him and remind him because it has been a mentor for most of us, and we cannot forget it. I think it's one of the best teachers we had in the respiratory medicine ever. So thanks to Tobias, and my condolences to his family. And I think Michael and the rest of EMBAC team will agree with me.
Of course, it's a huge loss to the bronchiectasis, to the respiratory community. So thank you very much, Letty. I'm afraid we're run out of time, but
I'm sorry.
There's a lot of questions, very interesting questions. So I want to just advertise the patient conference this Saturday. And there's a link, so encourage your patients to join. It's this Saturday, and of course they can also view it later. And we have 3 more webinars on the series. The microbiology of stable bronchiectasis by Dr. Cohen from our center, about the second one about physiotherapy from Spinu, and finally radiology and bronchiectasis. So please stay tuned. We'll advertise these. And I thank all of the audience for very, very interesting questions and inspiring questions. And of course, Eva and Letty, thank you very much. And see you all next time.
Thank you, Michael. Thank you, everybody.
Bye-bye.